Welcome to The Explainer. We're diving headfirst into the highly testable, frankly fascinating world of gastrointestinal pathology. Whether you're actively prepping for your United States medical licensing exams or you're just here to solidify your clinical knowledge, we are going to break down the absolute heavy-hitting structural and mucosal diseases of the gut. We'll be moving purely anatomically today. We'll start way up at the absorptive surfaces of the small intestine and we'll travel all the way down to the vascular cushions of the anal canal. Let's get right into it.
We're starting off with a real medical mystery, one that perfectly illustrates our first major topic. Think about the case of David Murphy. He's a 44-year-old guy presenting with a 7-month history of chronic diarrhea, significant weight loss, and stools that are yellow, foul-smelling, and, very notably, floating in the toilet. Now, just to put that into perspective, normal stool output is somewhere around 100 to 200 grams a day. David's output, massive. We're talking over 4,100 grams. And even more critical for your board exams is his fat excretion. He's losing 17 grams of fat a day when normal is strictly less than 5 grams. So this severe steatorrhea, combined with those floating stools, points us squarely toward a major systemic issue.
To really understand David's symptoms, we have to define exactly what's happening. We're looking at malabsorption syndrome. This classically presents with a specific clinical triad you've got to know: chronic diarrhea, abdominal distension, and a failure to thrive or grow. It is essentially a complete breakdown in the body's ability to extract nutrients from food. But here's the thing. This breakdown isn't just one single event. It can happen because of defects in the initial digestion of the food or in the subsequent absorption of those nutrients by the intestinal tract.
So this breakdown can strike in 3 distinct phases: luminal, mucosal, or post-absorptive. And this sets the stage perfectly for our small intestine disorders. In the luminal phase, we absolutely need our pancreatic enzymes and bile. If you've got a patient with chronic pancreatitis or cystic fibrosis, they're getting a defect right there. Then there's the mucosal phase, where the brush border enzymes and enterocytes do all the heavy lifting. This is exactly where conditions like celiac disease strike. Finally, the post-absorptive phase. This phase relies heavily on lymphatics to transport absorbed fats. Now here's a highly testable fact. If a patient has a GI malt lymphoma blocking that lymphatic drainage, they're going to malabsorb fats and proteins. But interestingly, their carbohydrate uptake remains totally fine. Why? Because carbs just don't use the lymphatics.
Section 1. Celiac disease and the mucosa. So, getting back to our patient, David, celiac disease is his actual diagnosis. And the pathophysiology here, absolute high-yield gold for the boards. When a susceptible patient eats gluten, which you'll find in wheat, barley, and rye, it gets broken down into gliadin. That's a 33-amino acid polypeptide. Then an intestinal enzyme called tissue transglutaminase, or TTG, catalyzes the deamidation of this gliadin. This creates these gliadin-TTG complexes that trigger a severe, and I mean severe, autoimmune T-cell response. Specifically, it's the cytotoxic T-cells that mediate the actual physical destruction of the enterocytes. And do not forget the genetics. This whole cascade happens in individuals with HLA-DQ2 or HLA-DQ8 cell surface receptors. Over 99% of celiac patients carry these specific HLA types.
On a microscopic level, the damage is essentially a war zone. An endoscopy will reveal a complete loss of the normal duodenal circular folds. On a biopsy, which, by the way, is the criterion standard for diagnosis, you'll note total villus atrophy and crypt hyperplasia. Normally, your villus to crypt ratio should be about 4:1. But here, the absorptive surface is completely flattened out while the crypts actually elongate in this desperate compensatory reaction. You'll also see vastly increased intraepithelial lymphocytes. We're talking greater than 20 per 100 epithelial cells. Diagnostically, you're looking for wildly elevated IgA-TTG antibodies and IgA-EMA, which are anti-endomysial antibodies directed against connective tissue proteins.
Clinically, these patients are going to show the classic malabsorption signs: voluminous, frothy diarrhea, and bone loss from vitamin D and calcium malabsorption. But beyond the gut, you really need to keep an eye out for extraintestinal symptoms. A classic board exam clue is dermatitis herpetiformis. It's this intensely itchy papulovesicular skin lesion that pops up on the extensor surfaces, like the elbows and buttocks, and you'll see it in about 10 to 20% of patients. Furthermore, you've got to remember these patients have a severely increased risk for entropathy-associated T-cell lymphoma as well as small intestinal adenocarcinoma. The only real treatment? A strict, absolutely lifelong gluten-free diet.
Section 2. Other small bowel disorders.
Okay, let's do a rapid-fire breakdown of some highly testable buzzwords, because these rare diseases absolutely love to pop up as differential diagnoses. First up, Whipple disease, caused by the actinobacterium Trophorema whipplei. You're looking for PS-positive, acid-fast negative foamy macrophages in the lamina propria, often linked to HLA-B27. Next is abatilipoproteinemia. This is an autosomal recessive mutation in the MTTP gene. Without MTTP, you simply cannot assemble chylomicrons. That means zero fat absorption, which leads to striking acanthocytes, or spur cells on a blood smear, all because of lipid membrane defects from missing those essential fatty acids. Then there's microvillus inclusion disease, driven by a MYO5B gene mutation that halts the transport of vesicles to the enterocyte apical membrane, leaving PS-positive vesicles just trapped inside the cell. Finally, autoimmune enteropathy, which typically presents with severe infant diarrhea. Watch for syndromic forms like IPEX syndrome, caused by a FOXP3 mutation that totally wipes out regulatory T cells, or APOCID, caused by an AIRR gene mutation that ruins central immune tolerance. I know it's a bit of an alphabet soup, but remembering these specific genes and markers is practically guaranteed points.
Contrasting these two common acquired mucosal conditions is also pretty essential. Environmental enteric dysfunction, or EED, is acquired via chronic fecal-oral contamination, and it's most often seen in developing nations. It causes villus blunting and inflammation that releases cytokines, which actively decreases a child's appetite and inhibits bone growth plates, leading to severely stunted growth. The good news? It is fully reversible if the patient changes environments. Now contrast that with lactase deficiency. While there is a super rare congenital LTC gene mutation, the most common form by far is acquired primary lactase deficiency. It affects about 50% of U.S. adults due to a totally normal aging decline of the lactase enzyme. It doesn't stunt growth at all, it just causes osmotic diarrhea and bloating because the colonic bacteria end up fermenting the unabsorbed lactose.
All right, having thoroughly covered the small intestine's mucosal and absorptive failures, we are now going to travel downward anatomically. We're leaving the world of absorption behind and entering the colon to examine the mechanical and structural defects that account for a massive percentage of gastrointestinal complaints in adults.
Section 3. Diverticular disease of the colon.
Diverticular disease is just incredibly common in Western societies. It's estimated that 5 to 10% of the U.S. population has colonic diverticula by age 40, and that skyrockets to 60 to 70% by age 80. Now keep in mind these are pseudo-diverticula, meaning they are not full-thickness outpouchings of the bowel wall. What happens is high intraluminal pressure, often from trying to move viscous stool due to a low-fiber diet, forces just the mucosa and submucosa to herniate outward. This herniation happens precisely at the points of greatest structural weakness. Where is that? Exactly where the vasa recta, arterial blood vessels, penetrate the tunica muscularis muscle wall. They typically form in parallel rows between the longitudinal muscle bands called tinea coli, and you'll predominantly find them in the sigmoid colon.
It's really vital to distinguish the clinical terminology here. Diverticulosis just means the sacs are there. Up to 80% of people who have them are completely asymptomatic. But when inspissated food particles block the neck of a sac, it leads to bacterial overgrowth and acute diverticulitis, which classically presents as constant left-sided lower abdominal pain. The complications here are highly testable. A ruptured pericolic abscess can form fistulas, like a colovesical fistula leading to pneumaturia, literally, air in the urine. Also, because these sacs form right alongside the vasa recta, medial thinning of those arteries can lead to massive, painless hematochezia, meaning bright red blood per rectum. And importantly, do not confuse these acquired colonic false diverticula with a Meckel's diverticulum. Meckel's is a true congenital pouch containing all three bowel wall layers, and it's located way back up in the ileum.
Section 4. Vascular defects, angiodysplasia and hemorrhoids.
Let's move to the lowest parts of the GI tract and examine two high-yield vascular defects that frequently present with gastrointestinal bleeding. First, angiodysplasia. These are abnormal, tortuous, dilated mucosal and submucosal blood vessels that actually lack smooth muscle. Unlike diverticula, which really favor the left colon, angiodysplasia typically strikes the right colon, specifically the cecum, and usually in older adults over age 60. It's driven by intermittent, recurrent, low-grade obstruction of submucosal veins right where they pierce the muscularis propria. Over years, this back pressure dilates the venules and capillaries, creating these 5 to 10 millimeter flat, red, radiating lesions that can cause episodic, totally painless gastrointestinal bleeding.
Finally, moving right down to the anal canal, we hit hemorrhoids. For your exams and for clinical practice, the absolute key here is the dentate or pectinate line. This one anatomical border dictates everything. Internal hemorrhoids originate above the dentate line from the internal hemorrhoidal plexus. They are covered by columnar epithelium, which receives visceral innervation, meaning they are not sensitive to pain. They drain into the superior rectal vein, which connects up to the portal system. External hemorrhoids, on the other hand, originate below the dentate line from the external plexus. They're covered by modified squamous epithelium and receive somatic nerve innervation. Therefore, they are exquisitely painful, especially when thrombosed, and they drain via the inferior rectal vein into the inferior caval system.
The breakdown of our normal anal cushions is what leads directly to this pathology. Your normal anal cushions, located at 11, 3, and 7 o'clock, are totally vital for proper anal closure. But matrix metalloproteases can actually degrade their supporting fibroelastic tissue. Combined with straining, the cushions simply slide down and prolapse, obstructing venous return and causing these enormously dilated vessels. And crucially, this is a big one for your differential diagnosis, keep in mind that hemorrhoids are entirely distinct from rectal varices. Rectal varices are actual portosystemic collaterals caused by portal hypertension. Hemorrhoids are not caused by portal hypertension. In fact, their prevalence is exactly the same whether a patient has liver cirrhosis or not.
As we wrap up this explainer, I want you to consider the thread connecting all these conditions, from the gluten-triggered autoimmune destruction we saw in celiac disease to the low-fiber-induced pressure blowouts of diverticular disease, all the way to the straining-induced prolapse of hemorrhoids. How deeply are our everyday dietary and lifestyle choices reflected in our anatomical pathology? It really leaves us to wonder just how much of GI disease is truly in our own hands. Thank you so much for joining me. Keep studying hard, and I'll see you in the next explainer.